Hello everyone, it's Dr. Locklear here, and I'm coming to you with our continuation on the concept of fluid and electrolytes, and we're going to specifically look at Exemplar 6.A on page 377, and now we're going to talk about how these imbalances in electrolytes affect us. So we will be talking about hypo and or excess fluid volume and dehydration. We will be talking about fluid volume depletion, where we're looking at that we don't have enough fluid. So we're going to look at overload and underload, okay? So our learning outcomes, the pathophysiology of fluid volume deficit and dehydration. And so what is included in that particular piece? How does that occur? What are the causes of fluid volume deficit and dehydration? Compare the risk factors and how do we prevent it? Identify clinical manifestations of fluid volume deficit and dehydration. So what will you see as a nurse when you do your assessment? What are the diagnostic tests? And a lot of what I'm going to say with this recording has already been said in the actual concept recording of fluid and electrolyte. So a lot of this may be repetitive to you. We're going to look at considerations for care of patients with fluid volume deficit and dehydration across the lifespan. And we talked a lot about that on the other recording. And how do we apply the nursing process? How do we focus on assessing and implementation? And a lot has to be done with these patients. So our overview, the balance of fluids and electrolytes is delicate and easily disrupted by illness, injury, stress, or strenuous activity. So sweating a lot, losing a lot of fluid, illnesses, nausea, vomiting, diarrhea, chemotherapy, cancer, those type of, or just stomach issues and you can't eat. Mild imbalances are resolved quickly by the body, often without any outside intervention. If intervention is required for a mild fluid or electrolyte imbalance, there is seldom any residual effect. So we look at factors such as illness, trauma, surgery, and medications can affect the body's ability to maintain fluid and electrolytes. Patients who are confused, experiencing dementia, or unable to communicate their needs are at greater risk for inadequate fluid intake. Vomiting, diarrhea, or nasogastric suction can also lead to fluid volume and electrolyte imbalances as well. The kidneys play a major role in maintaining fluid volume and electrolyte imbalance. Renal disease is a significant cause. So when your kidneys aren't filtering properly, you're going to have a buildup of fluid. Tissue trauma such as burns, crush injuries causes fluid and electrolytes to be lost from damaged cells. Decreased blood flow to the kidneys from impaired cardiac functioning stimulates the renin, angiotensin, aldosterone system, causing sodium and water retention. Medications such as diuretics or corticosteroids can result in abnormal losses of electrolytes and in fluid loss or retention. Complications from diabetes, cancer, again, the chemotherapy making you nauseated and diarrhea, head injury, and with the head injury, you may have a lot of nausea with a head injury as well. Fluid and electrolyte imbalances are classified in fluid volume deficit, fluid volume excess, and electrolyte imbalance. So fluid imbalances are of two basic types. You have isotonic, which occurs when water and electrolytes are lost or gained in equal proportions, so the osmolality of body fluids remains constant. Osmolar imbalances involve the loss or gain of only water, so the osmolality of the serum is altered. Four categories of fluid imbalance occur: fluid volume deficit, fluid volume excess, dehydration or hyperosmolar imbalance, or overhydration. So any of these four listed with these imbalances It's got to be right. Remember from the other recording, we've got to have homeostasis. So what is fluid volume deficit and dehydration? It is a decrease in intravascular, interstitial, and/or intracellular fluid in the body. It's a relatively common problem that may exist alone or in combination with other electrolyte or acid-base imbalances. Dehydration refers to the loss of fluid alone, even though the term often is used interchangeably with fluid volume deficit or dehydration. So when we're losing fluid, we are in a negative balance. We don't have enough fluid in our system. So what is the patho? Fluid volume deficit can occur slowly or rapidly depending on the type of fluid loss. Loss of extracellular fluid volume can lead to hypovolemia, which causes decreased circulating blood volume. Often electrolytes are lost along with fluid, resulting in an isotonic fluid volume deficit. When both water and electrolytes are lost, the serum sodium level remains normal, although levels of other electrolytes such as potassium may fall. Fluid is drawn into the vascular compartment from the interstitial spaces as the body attempts to maintain tissue perfusion. This eventually depletes fluid in the intracellular compartment, so intracellular meaning within the cell, and then we have a higher concentration. Remember, concentration is thick. Hypovolemia stimulates regulatory mechanisms to maintain circulation. The sympathetic nervous system is stimulated, as is the thirst mechanism. Antidiuretic hormone and aldosterone are released, prompting sodium and water retention by the kidneys. Severe fluid loss can lead to cardiovascular collapse. And so we have some terms here: isotonic dehydration, hypotonic, and hypertonic. Depending on the causative deficit, sodium may be at a normal, low, or elevated level. So in isotonic, the sodium level is normal, may result from vomiting, diarrhea, or hemorrhage. Hypotonic dehydration, you have proportionately more sodium loss than water loss, so may result from severe prolonged vomiting and diarrhea and burns. So we're losing sodium, which can affect our muscles and that heart muscle. Hypertonic is proportionately less sodium loss than water, may result from end-stage renal disease, so we may have too much sodium, which can affect our muscles and heart as well. We also have something that's called third spacing, and this is when fluid and electrolyte balance is essential to supporting vascular function. A shift of fluid from the vascular space into an area where it is not available to support normal physiological process is known as third spacing. The trapped fluid represents a volume loss and is unavailable for normal physiological processes. Fluid may be sequestered in the abdomen or the bowel or in other actual or potential body spaces, such as the pleural or peritoneal space. Fluid may also become trapped within soft tissues following trauma or burns. And so you've got fluid in a space that it shouldn't be in, and it is trapped, and it's difficult to assess, and it should not be there. The blood vessels and tissues can be damaged. It can cause inflammation, such as histamine and prostaglandins kick in. Third spacing is difficult to assess because it may not be reflected in measurable data. The fluid accumulates in the interstitial tissues, and so you may see like bubbles of skin, the skin bulging, and it may sound crackly and feel crackly when you touch it, like plastic wrap or something. Excessive fluid volume loss. Most common excessive loss is the GI fluid, and so what you see is vomiting, diarrhea from GI suctioning, interstitial fistulas, and intestinal drainage, diarrhea and things like that. Other causes of fluid loss are diuretics, renal disorders, endocrine disorders, excessive renal losses, sweating heavily, water and sodium losses, and we talked a lot about that in the other recording. Hemorrhage, we didn't really mention hemorrhage, but bleeding causes us to lose vascular volume, and of course, hemorrhage leads to death. We can't bleed out. And then chronic abuse of laxatives and enemas as well. Inadequate intake, lack of access of fluids, you're just not drinking enough, inability to swallow, maybe you've got throat cancer and you're just not able to take in, you've got some oral trauma, you have an altered thirst mechanism, maybe you've had a head injury and now it's your brain's just not kicking in saying, hey, I'm thirsty. Maybe your angiorenin and aldosterone system is out of whack from the head injury. Excessive exercise during hot weather. We talked a lot about that. We talked about burns. You lose the layers and protective skin layers that help us maintain our water. And when you have burns, these leak out. And so as it says, it leaks into the interstitial spaces, and so you're losing a lot of sodium. Hypotonic dehydration in initial period after a burn, you have a high loss of extracellular fluid in a burn because, like I said, the skin is gone, those layers of protection are gone. Also loss of intracellular in the long term with burns. Factors preventing normal intake, and this, maybe you're NPO because you've got a bleeding ulcer, you've been vomiting, or you've got a procedure to go to. That's why when children have procedures done, they do them first thing in the morning because they can only go so long without some fluids. They can't go as long as an adult can. So NPO status, dysphagia, difficulty swallowing, lack of potable water. Maybe you're living in an area that you don't have clean water to drink, or you just had a hurricane like we've had here recently. Inaccurate fluid replacement compared to the loss. Maybe you've lost more than you're taking in. Because, when you're sick, especially when it's something GI related, you're nauseated. You don't feel like eating or drinking anything. Fluid shifts due to burns, albuminuria, and diabetes insipidus, and that's another form of diabetes where you lose a lot of fluid. Other factors are diarrhea, burns, nausea, vomiting, acute or chronic renal failure, hemorrhage, and diabetic ketoacidosis, and we talked about those a lot in the other recording. Fluid volume deficit and dehydration prevention. So what are we looking at here? A significant amount of fluid is lost to the body through sweating, perspiration, especially in hot or humid weather, or in cold weather when sweating occurs under heavy clothing. You can get too hot because you're bundled up too much. Some artificially heated indoor air can cause skin to lose moisture, requiring replacement. Altitudes greater than 82,000 feet increase the need for water because the air becomes drier and the increased breathing rate stimulates so the more you breathe, the more you're expelling through respiration, as we saw in the concept. 300 to 400 milliliters is lost through respiration. Fluid loss through respiration may also become significant if the individual is exposed to very cold, dry environment for an extended period of time. Prevention involves drinking enough fluids to replace fluid loss to environmental factors. Electrolyte fluids in moderation rather than just water. Be careful, like I said, with Gatorades and Pedialyte and things like that. You should not be drinking these unless you actually have a situation where you need to replace. Just drinking water on a daily basis is the best thing. Encourage water consumption by younger children and older adults. A lot of kids don't want to drink water. They don't care for it. Fluid volume deficit and dehydration with the clinical manifestations. So initially you're thirsty. Later symptoms, you start to have changes in your mental status. You're lethargic, you're weak, you have dry mucous membranes, your urine output becomes very decreased, and so you may not go to the bathroom for 8 hours and put out anything. If not treated, you will have coma and death. We've got to remember, remain that homeostasis, that balance. Loss of interstitial fluid leads to diminished skin turgor. So when you're looking at your assessment, you need to look at the skin, check the turgor of the skin. Postural orthostatic hypotension can occur. This is a sign of hypovolemia, that you don't have enough vascular volume to maintain the blood pressure. And then the compensatory mechanisms kick in, and you will see like tachycardia, because the heart's trying to beat as fast as it can to pump what fluid it can to maintain the organs functioning. So it's going to beat faster to pump what it can. Pale, cool skin, because it does affect our thermoregulation, which is another concept that's related to it, and decreased urinary output. We need to monitor the urinary output very frequently, every 2 hours, especially with a compromised patient. Safety alert, because rapid weight loss is a good indication of fluid volume deficit. It is critical to weigh patients who are at risk daily. Each liter of body fluid weighs approximately 1 kilogram, 2.2 pounds. The severity of fluid volume deficit can be estimated by the percentage of rapid weight loss. So we need to weigh these patients every day at the same time in the same clothes, and they need to empty their bladder before you weigh them. Diagnostic testing. Before we go to that, look on page 380 and 381. On 380, it shows you the multi-system effects of fluid volume deficit. Please read over that. I just basically mentioned all of them, but this is a good picture where it's all consolidated into one area. And then fluid volume deficit and dehydration, the clinical manifestations. Again, all of these were mentioned in the concept on fluid and electrolytes. But, you know, one of the things that you need to look at is increased hematocrit, tachypnea. We really didn't talk about respirations using that term in the concept. We talked a lot about tachycardia. And so you will see increased respirations, and the more you breathe, the more fluid you're getting out. So that's not a good thing. Make sure you look at those two things on page 380 and 381. So diagnostic test, serum electrolyte panel. In severe continuing dehydration that's complicated by electrolyte imbalance or acidosis, the physician will order an electrolyte panel. It looks at the electrolytes, the creatinine, the BUN, glucose test. It looks at the urine-specific gravity. It looks at the osmolality. It looks at the concentration of the urine. How concentrated is it? And one of the things that you will see is that the specific gravity may not be seen in dehydration. You have to have more severe cases, but it will start to rise. And the urine will look very dark and may look tea-colored, and you have to describe it as that way. Some of the clinical therapies, oral rehydration. So this is the safest, most effective treatment, but you don't want to do it too quickly. Mild fluid deficit, water alone will help get you back on track. For more severe fluid volume deficits, sports drinks, ginger ale, Pedialyte, and Rehydrolyte. Replace fluids gradually, especially in older adults, because if you replace them quickly, you can throw them into fluid volume overload, especially if their kidneys and their heart are not functioning as they should, and it can't handle that much fluid at one time. Intravenous fluids, we talked a lot about intravenous fluids, and it lists those same fluids again on page 382 that we talked about in the concept. Normal saline, half normal saline, lactated ringers, D5W. All of those are some of the fluids that you would give according to whether it's you need isotonic or hypertonic. Children. So how is this affected in children? The sources of fluid loss, which can be way quicker in a low birth weight infant, because they have to go under the warmers, and it causes, you know, to have perspiration. If you'll notice on the picture on page 382, the baby doesn't have any clothes on, and that's typically what you'll see. You put them under the warmers, and all they have on is the diaper. Higher body surface area, increased respiratory rate, more insensible fluid loss through the skin and lungs. Increased risk for fever because their body is still immature, so fever causes them to sweat, and that makes them more prone for losing fluid. More prone to vomiting and diarrhea, especially this preterm baby, because the preterm things aren't quite developed yet. More likely to experience an imbalance from exercise, and this would be, of course, children and adolescents. Adrenal insufficiency and accumulation of extracellular fluid in the third space. And then again with the diuretics, you see this a lot in adults. Adults often take a lot of diuretics, and sometimes it gets the fluid out too much. And so look on page 384. It talks about dehydration risk factors and symptoms in the older adult. And I've already pretty much mentioned most of these, so read back over this list as a reference. Dry oral mucous membranes and tongue furrows. Tongue furrows, like fuzziness on your tongue, they're indicative of dehydration, and the tongue and lips will be dry and cracked. Chronic dehydration results in dry, itchy skin, dull appearing brittle hair, and loss of thirst reflex. Orthostatic or postural hypertension may be unrelated to hydration status. Vital signs may not demonstrate typical changes in the older adult who is dehydrated. Other common signs of dehydration, such as dry oral mucous membranes and upper body weakness, and complaints of muscle weakness. Those type of things you will see when you do your assessment. With children and adolescents, mild dehydration is hard to detect in the pediatric patient. They may just be irritable and crying a lot, and thirst in children. Moderate dehydration, you're going to see lethargy, sleeplessness, restlessness. They're irritable, crying, poor skin turgor, dry mucous membranes, increased pulse, tachycardia, hypotension, seizure activity because of the irritability to the muscles, and decreased or absent urinary output. The treatment in children, and again, this really needs to be under, the direction of a physician. For mild dehydration, children and adolescents, oral hydration or frequent small amounts, like every hour, every 2 hours, small amounts. Hospitalized children in severe dehydration, you're going to do some of the IV fluids, and you're going to administer slowly. You don't want to throw them in fluid volume overload too quickly, and you may give them some Pedialyte and Gatorade. Pregnant women, risk for fluid volume deficit, especially in the first trimester. Vomiting. You have a lot of nausea because your hormones are elevated, and it does not agree with the normal flow of your stomach, and so you have this nausea because your hormone levels are elevated, and the more they get elevated to maintain the pregnancy, the more nausea you may have. Patient teaching on how to avoid dehydration, proper fluids to consume, water. Do Gatorade under the direction of the physician. Avoid caffeine, alcohol, and diet drinks, because diet drinks often are high in sodium and that type of thing, and we don't want to add if we're dehydrated but we've got too much sodium. In older adults, the increased risk for rapid dehydration, you have fewer intracellular reserves, blunted thirst perception. Your brain just doesn't work like it used to because it's aging, and you just don't get thirsty. And a lot of older people are sitting around, they don't burn up a lot of energy either. And then the changes in the hormones. Increased risk for balance, changes in mentation, your cognition, altered mental status. And then the adverse effects of medications. And so, you will see with the older adult that the diuretics and some other medications will lead to dehydration because some of medicines cause us to lose our appetite, and so we don't want to eat or anything. Older adults, this is a picture of the tongue with the furrows on it, and so early signs, and I said this when I recorded the concept: change in mental status, memory, attention span, poor skin turgor, the dry mucous membranes, the little furrows again on the tongue, dry, itchy, brittle skin. So that brings us up to assessment. Your safety alert on page 384 is talking about orthostatic or postural hypertension. Again, observe, during the interview, ask the patient about risk factors, medications, diuretics, medications that are zapping their appetite. You need to get a full list of their medicines. Renal and endocrine disorders. Do you have chronic kidney disease? Precipitating factors. Are you eating? Are you drinking? How's your appetite? Do you have access to adequate fluids and food? Any recent illness that caused you to have a fever or pneumonia or something where you were on antibiotics that caused diarrhea. So under assessment, it talks about a term called anorexia. The nurse should monitor fluid intake in patients with decreased level of consciousness, disorientation, nausea, and anorexia, which is loss of appetite, and physical limitations. The nurse should also assess hydration by looking at the skin for dryness, flakiness, or scaliness, as well as tinting when the skin is pinched, poor skin turgor. So under our observation, again, we want to look at those risk factors: renal disease, heart disease, been out in the hot weather, do you have access to food and fluids, how's your appetite? Physical exam, how is their weight? Have they lost weight? Are they on the diuretics that's causing weight loss? Are they tachycardic? Do they have bounding peripheral pulses? Is their capillary refill sluggish? Jugular vein distension. Can you see the veins bulging in the side of their neck? And you assess that. Feel those pulses in the neck to see if they're bounding. Skin color. Is it pale? Is it cool? Is it clammy? How's the turgor? What is their mentation? And that should be the first thing that you look at, is their mental status, and of course their urine output. Here are your nursing diagnoses: fluid volume deficit, peripheral tissue perfusion ineffective, risk for injury, confusion, and activity intolerance. Our goals: achieve fluid and electrolyte balance, drink 1,500 milliliters at least a day, replace fluids with sports drinks, return to the normal hydration status. For children, we want to prevent dehydration quickly. So do we let our kids play sports in the hottest time of the day? We need to be very mindful of that. Your implementation, this is on page 385. And you have a very detailed list here. Record the I. Oh, I can't stress that enough. I actually saw in clinical just recently where a nurse didn't feel the need to document an output on a patient, and that we need this data. Hourly I-NO may occasionally be indicated. Weigh the patient daily with the same scale and in the same or similar clothing, and they need to empty their bladder before you weigh them. Take their vital signs every hour if you need to. Assess those pulses. Are they bounding? Are they pounding? Are they tachycardic? Administer and monitor intake of fluids as prescribed. Administer IV fluid using the electronic infusion pump. The fluid should be on a pump and regulated at an accurate rate. You don't want to infuse too fast and throw them into overload. We want to look at the electrolytes: sodium, potassium, calcium, magnesium, phosphorus, chloride, the BUN, the creatinine, because this shows us if the kidneys are filtering. The osmolality also shows us if the urine's too concentrated, along with the urine-specific gravity. Monitor for changes in level of consciousness. Is it an altered mental state? Reposition every 2 hours, because you don't want these fluids, you're replacing, you don't want them to settle. Institute safety precautions to avoid falls because they may be confused and dizzy. Teach patients how to reduce orthostatic hypotension. And so what do? We sit them up slowly. We move them slowly. We don't get them out of the bed fast. Teach parents not to give diet beverages because they have a high content of sodium and potassium in them. We don't want to throw them in overload. And evaluation, of course, evaluation, everything returns to within normal limits. So that's fluid volume deficit. Fluid volume excess, this results when both water and sodium are retained in the body. Fluid volume excess may be caused by fluid overload, excess water and sodium intake, or by impairment of the mechanisms that maintain homeostasis, leading to excess intravascular fluid or hypervolemia. That's what I was trying to remember when I first started this. Hypovolemia, hypervolemia. This is an excess, so we have too much. So it's going to cause swelling, which impairs our circulation. It impairs our ability to breathe because we got too much fluid going through our circulatory system in our lungs. We feel short of breath. We've got too much fluid being pumped through our heart, so the heart's going to pump harder and it's going to wear out faster. Yeah, again, you will see edema in the lower extremities, and you may see pitting edema. So again, too much fluid in the interstitial, too much fluid in the extracellular compartment. Let me make that very clear. Not in the cell, out of the cell. An increase in total body sodium content. So you will see changes in the sodium content, and we know that sodium causes fluid retention. So you'll have increased blood hydrostatic pressure, decreased blood colloid osmotic pressure, blocked lymphatic drainage, and swelling. The fluid has nowhere to go because nothing is working right. So what is our etiology? Before we go to etiology, look on page 386, and it talks about increased blood hydrostatic pressure. It gives you a good definition of that. Decreased blood colloid osmotic pressure. This is the osmotic pressure that pulls fluid into the capillaries, results from the presence of albumin or other plasma proteins by the liver. So make sure you read over those, okay? And then you have box 6-3, and these are clinical conditions that cause edema. And edema is never good. We don't want edema because we know if we have edema, that is a sign that fluid is being retained, especially if it's in both feet and ankles and your hands. You feel short of breath. Your heart just is pumping away. So what is the etiology? What causes fluid volume excess? Conditions that cause retention of sodium and water. So heart failure, your heart just can't pump. Cirrhosis, the liver just can't filter. Renal failure, your kidneys can't filter. Adrenal gland disorders, they can't filter either. Corticosteroids, corticosteroids are very good at reducing inflammation, but they do have a lot of side effects, and they do cause the tissues to retain fluid just like sodium does. And then again, stressful conditions. Other causes, excessive intake of sodium, just adding too much salt to your food and eating those high processed foods that are full of sodium. Drugs that cause sodium retention and excess amounts of sodium containing in the IV. What are the risk factors? Preeclampsia. So if you get too much fluid, you could have preeclampsia, and this is where the blood pressure just goes really, really high. You're going to learn about this in 113. You have a lot of swelling, sudden weight gain, and usually the only cure is the delivery of the fetus. Other risk factors are heart disease because your heart pumping action can't pump all that fluid. Again, kidney problems, diabetes, hypertension, and fluid volume overload just through IV therapy. What is our prevention? We want to focus on diseases that lead to overload, so they got to treat the heart disease and the kidney disease and those type of things. Diuretics, but you have to be careful with diuretics because they can get the fluid out too fast and they can cause you to lose potassium, as I said in the other recording. Antihypertensive medications to keep the fluids in balance. Weigh daily. If you gain 2 to 3 pounds a day, that's too much. You need to notify the healthcare provider. Uh, don't add salt. No added salt. That's a diet. It's called NAS. No added salt. Just eat what the food itself is and stay away from processed meats and canned foods. Frozen vegetables are much better. And elevate your extremities when you're sitting. Get your feet up so the fluid can come back up into the system. Clinical manifestations, and you have some terms here. Dyspnea, this is labored or difficulty breathing. Orthopnea, difficulty breathing when lying down supine. Polyuria, greatly increased urine output. Ascites, this is excess fluid in the peritoneal cavity. Again, this is where fluid should not be, and it has no function there, and it just sits there, and you get larger and larger because your liver is not able to filter the fluid, usually from cirrhosis of the liver. Anasarca, this is severe or generalized edema. Anasarca, that's the way you say that. You will have a full bounding pulse. The distended neck veins, you can see them bulging on the side of the neck. You have increased CVP, more than 11 to 12 centimeters of water. Cough, dyspnea, orthopnea, crackles in the lungs, polyuria, ascites, cerebral edema, and that can lead to seizures. Our collaborative efforts, prevention is the key. So, limiting sodium intake, being careful with the type of diuretics that they're on, correct the underlying causes, and consult with the dietitian. Diagnostic tests, again, these are pretty much the same as with fluid volume depletion. So, you want to look at electrolytes, you want to do a chemistry panel, and you want to look at renal and liver function tests as well. Loop diuretics, these will get rid of potassium. Thiazides and potassium-sparing diuretics are also useful because we got to maintain that balance of potassium. Fluid management, you want to restrict fluid because we're in excess. They may be on 1,000 milliliters a day. So what you do is you empty their water pitcher, you turn it upside down in the room, and a sign goes up, and you calculate how many milliliters the person can have per shift. And it's calculated including your meals, your medicines, and all foods. So you'll have to have help with the dietitian to do this. And sodium restricted diet as well. Infants and children. Newborns, again, are at the greatest risk. I'm really not going to go back over this. You can read this for yourself. This is on page 389. I have talked a lot about that as well. There's a box on 389, 6-4, Fluid Restriction Guidelines. And so it talks about subtracting the requisite fluids and then divide the remaining fluid allowance. And I'm not really familiar with that process. All I know is I'm used to, if the doctor says 1,000 milliliters, we calculate how much they need on each shift. So just read over that. Again, for infants and children, we've talked a lot about fluid issues. And so if they're in excess, again, we want to see what the cause is. Are they getting too much fluid? Do they have heart problems, lung problems, kidney problems? And a lot of times in children, it is underlying conditions. Again, pregnant women, they can have preeclampsia. It can happen very quickly, and they can get gain a bunch of weight, have excess amniotic fluid, which is polyhydramnios, and their blood pressure is like really high, like stroke level, 220 over 120. They need to be taken to the hospital immediately, and delivery of the fetus is usually the only cure. You will see protein in the urine as well with preeclampsia. Older adults, it's usually from heart failure or kidney failure. We've already discussed that. So just read over that again. The nursing process, so again, we want to prevent fluid volume excess, manage the problems, treat why. Why is this patient, why do they have too much fluid? Is it heart, kidney, lungs, liver, whatever? So in the assessment, are they short of breath? Is their heart rate bounding? Have they had weight gain? Are they coughing? Do they have no energy? Do they say that their heart feels like it's bounding? They have edema of the lower extremities and the feet, and it's pitting edema. Look at the picture on page 389. You're feeling for edema with your finger, pads of your finger. Bulging neck vein distension. This person is definitely in fluid volume overload. There's just too much fluid going through those vessels. And you see the physical assessment here, and we've talked about that already. Your nursing diagnoses, these are listed here for you. Excess fluid volume, impaired skin integrity, risk for impaired gas exchange because we've got too much volume going through our lungs and our heart. Perfusion could be one of those. Ineffective tissue perfusion because you've got too much fluid going through the heart as well. So just take a look at those. The goals, we want to regain fluid balance. We want to have clear lungs and a normal heart rate and normal vital signs. So how do we do that? Look on page 391. You have teaching of the low sodium diet. Again, you know, stay away from processed foods, carbonated beverages, diet drinks, fruits. Use more fruits and vegetables and lean meats. Stay away from medications that dry you up, like a decongestant. Sometimes you can take a allergy medicine like an antihistamine with a decongestant, and you will go all day without voiding, and that's not good because it does dry you up. Please read over that on page 391. Again, weigh daily, I&Os, administer oral fluids carefully, oral hygiene, talk to them and teach them about the diet changes and their medications and when to call the doctor. If you gain 2 to 3 pounds, you know, we need to call the doctor. Skin care, repositioning, monitor the O2 sats and your lab results. Call these to the physician. You know, if the patient continues to be short of breath and their sats are dropping, call rapid response. Call respiratory for a breathing treatment. Teach them how to use the incentive spirometer. Teach them about dietary choices. And then in evaluation, we want to make sure that the patient's back into a normal fluid balance. And then your chapter goes into electrolyte imbalances, and it's talking about here imbalances with sodium, hypernatremia, hyponatremia, imbalances with potassium. So if we have a electrolyte imbalances, and I'm not going to spend a lot of time here because I talked a lot about this in the other concept, but please read through page 393 and 394. You do need to know these terms. So the first one is sodium, 135 to 145, and we know sodium causes fluid retention. So reduce the salt in the cooking. Don't add salt. Limit high sodium foods. And I probably said that 100 times already. I know you're like, I don't want to hear that no more, Dr. Locklear. Monitor the medicines. You know, please be mindful. Check your labs. Notify the physician. Put it together. Hey, my patient's on Lasix and their potassium's 2.5. I need to do something. Okay, that's very important. And teach them about their diet. Okay, so you have two terms here: hypernatremia. So that means the sodium level is greater than 145, and hyponatremia, and that means it's below 135. And a lot of the things that causes it, I've already talked about. It's on your PowerPoint slide here and in the reading, because I'm trying not to, this recording's almost an hour long too, and a lot of this is repetitive. I got you a picture here of some good old pictures of stool, because one of the things that causes hypernatremia is diarrhea. You're getting rid of too much fluid and it retains the sodium in your body. Okay. Hyponatremia, change in mental status. And remember, with sodium, you're vomiting, diarrhea, NG suction, and you may see changes in mental status, okay, changes in blood pressure. Hyponatremia manifestations, weakness, fatigue, muscle cramps, abdominal cramps, levels less than 120, convulsions, coma, and death. Okay, and we want to manage that with the fluids that will reverse that. Potassium, we know that potassium is positively charged. Here are foods high in potassium: oranges, milk products, dried beans, legumes, salmon, avocados. I don't like avocados. They don't have any taste, but they are so good for you. We know it plays a role in cellular depolarization and repolarization, and this occurs with the pumping action of the heart. So you will get that when we get the perfusion in 211. And it talks about the potassium pump. This is where it moves into the cell while sodium moves out of the cell. Remember, you got to have that balance. You can't have too much of both. Hyperkalemia, greater than 5.3, renal failure, potassium sparing diuretics can cause it. You can go into a state of acidosis. Starvation can cause it. And then again, the cardiac problems, dysrhythmias, cardiac arrest, paresthesia with those muscles, management, administration of calcium gluconate. That is the do-all. Calcium gluconate, insulin, and glucose. And I already talked to you about the insulin. Okay. Hypokalemia, we don't have enough potassium. Less than 3.5, critical is less than 2.5. And so you need potassium replacements. And here are some of the causes. I already talked about that. Antibiotics, they cause diarrhea in some patients. Dysrhythmias, anorexia, muscle cramping. And so the management is replace the potassium. So we may have to give fluids that have potassium in them. I'm not going to spend a lot of time here on chloride, which is hyperchloremia and hypochloremia. Read that on your own, okay? Because we're almost at an hour here. Now, one thing about chloride, look at the changes in the respirations here, okay? So it can affect your breathing pattern. And so one of the treatments is dialysis. So chloride is a big deal. It is a big deal. Here again, just read the chloride on your own. Calcium, hypercalcemia, this is where greater than 11 milligrams per deciliter or below 9. The window for calcium is very narrow. It's 9 to 11. It helps with our neuromuscular functioning, control of muscle contractions, blood clotting, bone T formation, cellular membrane functioning, and it helps control vitamin D, calcitonin, and parathyroid hormone. Our body is complex, people, and we got to have a balance. Here's the thing. I know you're thinking, oh my God, these 2 chapters. Well, here's the thing about a nurse. Remember, we're not chemists. The thing you need to remember is monitoring the labs and the signs and symptoms of these electrolyte imbalances and reporting. You monitor and you report, and you do what you can. If they're short of breath, give them some oxygen. Call rapid response. You know, it's not our job to understand all the chemical background of this, so don't get overwhelmed. Our job is to look at these labs and assess the signs and symptoms of these disorders and assess and report. This is where nurses fail, when we don't assess and report, and we don't look at the labs and we don't take them seriously, okay? So again, hypercalcemia and hypocalcemia affects the neurological system. You have a decrease in these deep tendon reflexes right here, as you see. Headaches, changes in mental status, cardiac dysrhythmias. It can be just as bad as potassium. Foods rich in calcium, we want to make sure that we're providing a low calcium diet if we're hypercalcemic. Hypocalcemia, we just don't have enough, okay? And so we're going to still see some of the same things. Oh, this is where my tetany was. I knew I had read it. So in hypocalcemia, you let me see if I can find it here. Bradycardia and hypertension occur. Patients experience numbness and tingling of the fingers, hyperactive reflexes, muscle cramps, laryngeal spasms, and tetany occur, and possible seizures. So when you do put the blood pressure cuff on, the hand may jerk a little bit. Patients may exhibit that Trousseau sign and Vostek sign, in which case an IV replacement of calcium is indicated. So that would be your tetany right there. And then if the calcium is so low, you may have this Trousseau sign, that trembling and that shaking of the extremity there. Magnesium, hypomagnesium or hypermagnesium. I'm gonna just have you read that on your own. We've already talked a lot about that too. One of the things that you see with magnesium is muscles. It really affects your muscles. And so, if you see the picture here, complaining of the leg cramps and muscle spasms, tremors, please assess and notify the physician and let the physician know what the labs are. Phosphorus, 85% are found in bones and teeth, and these conditions are rare. So just kind of read this on your own. In children and adolescents, most imbalances are due to diarrhea and GI problems that lead to fluid volume deficits. And then again, in pregnant women, just read over that. It's very short there. Again, here are some of the changes that you see with the electrolyte imbalances, and we've already talked a little bit about this before, so I'm just going to keep right on going. Assessment. Again, we look at labs. Look at there, review of the labs. Look at the labs. Assess your signs and symptoms. Do an EKG. Look at your hemoglobin hematocrit. Do your O2 sats, your ABGs. And also, they will order a panel to look to see if you're going into a type of acidosis or alkalosis. So they'll look at your pH, and they'll look at your CO2, O2, and your bicarb. And we talked a little bit about that before. Assessment, again, we've already talked a lot about this. The dry, cracked lips, anorexia, muscle cramping, diarrhea. You should have that by now, okay? Again, vital signs, the mental status exam. We want to assess that cognitive status. Deep tendon reflexes, are they absent? Are they hyperactive? Diarrhea or vomiting, heart and lung sounds, are the heart bounding, are the lungs congested? Does it sound like there's just too much fluid in there? We want to focus on foods high in sodium or potassium, or restrict these, okay, one or the other, okay? There's your diagnoses: fluid volume deficit, risk for electrolyte imbalance, decreased cardiac output, ineffective tissue perfusion. Goals: we want everything back in normal limits. Implementation: I've already said all of these. So if you read back over these, you will have it, because I've already said all these. I don't want to repeat. But again, you need to know how to observe for signs and symptoms of dehydration. Monitor the eyes and nose. Be able to teach patient about meds that cause fluid volume disorders and changes in your electrolyte disorders as well. And then evaluation. Did everything return to normal? Were the measures that we used appropriate, and were they effective? So remember, as you are working with patients with electrolyte disorders and imbalances with fluid volume, look at the labs, look at their vital signs, look at their signs and symptoms, and assess and report. Elevate the head of the bed, give them some oxygen. If they're dehydrated, they need fluid. If they're overhydrated, they need to get the fluid out. Call rapid response, call your healthcare provider, and document, document, document. Thank you.